Proprio. He has more than 10 years experience in product development, business strategy, IP law, and engineering. He has worked with the Gates Foundation, helping Bill Gates evaluate emerging healthcare technologies and initiatives. His session is entitled More Than a Simulation, How Mixed Reality Will Give Surgeons Superpowers. Gabriel, take it away.
Thanks for the intro. I'm Gabe Jones, CEO and founder of Proprio. Let's dive right in. In the previous presentations, you heard about the promise of XR in health for training, planning, even patient treatment, engagement, and recovery. We're going to talk about how Proprio is taking it even further to augment one of the most scarce resources in the world, a highly trained surgeon. This is the amplified human using immersive computing and calm design to enhance care. First, let's define some of the problems. In 2018, total healthcare spending in the US crossed $3.65 trillion with a T. It's a huge amount of spending. In 2027, it's expected to get worse. 5.7 trillion or 20% of US GDP. So the clear message here is that US healthcare spending is out of control. By 2022, annual healthcare spend per person in the US will hit $11,674 approximately. So how does that compare? Pakistan is $54. US ROI on all that spend is very poor. So we tend to rank between 30 and 50 in the world in terms of the quality of care that we're getting for those dollars. So we need to do better with that. Against that backdrop, the US population is aging and aging quickly. In 2016, we had 49.2 million people over the age of 65 in the US. By 2034, we're going to hit a unique point in history when the portion of the population that's over 65 will, for the first time ever, outnumber the people under the age of 18. This is not a one-time event. This is the new normal. In the future, that ratio will only move further with a larger portion of the population being over 65, and we need to address this issue. This is not just a US problem. If you look across the world, in Europe, in Japan, in India, of course, in the US and in China, the populations are aging, and the healthcare needs of the aging population will be exacerbated by several additional issues. This is a global problem. By 2032, we will have a shortage of physicians in the US of 121,900. This is also a global issue, exacerbated by a shortage of surgeons, which is expected to hit 23,400 in the US alone by 2032. These are highly trained surgeons that are hard to come by and need to take care of thousands of patients in the course of a year. A good example is my co-founder, Dr. Sam Brown. It took him 17 years, starting in 1990, to go from pre-med in college to being a practicing pediatric neurosurgeon at the University of Washington Seattle Children's Hospital. Here he is looking very cool in his black and white photo. He effectively lived in the hospital for 7 to 8 years while doing his residency, his neurosurgery rotation, and followed by a pediatric rotation. So how can we take the 17 years without sacrificing quality, perhaps even increase quality of that training, and shorten those 17 years significantly so we can bridge the gap in the shortage of surgeons globally and in the US? How far have we come in creating better doctors? So this grainy photo comes from a turn of the century medical school. These gentlemen are all studying what the lead surgeon is performing here. As you can see, I like to focus on this guy who looks a little bit like Matthew McConaughey in this photo. But my question to you is, would you want him to be your surgeon or the surgeon for one of your loved ones? I personally would not. He can't see what's going on here. Has it gotten any better? This is the 1960s, 1970s. These are a bunch of surgical trainees trying to see what the lead surgeon's doing. Would you want this guy to be your surgeon? I think not. Okay, fine. Let's fast forward to more recently. Here you've got Brigham and Women's or Mass Gen Hospital in Boston within the last 10 years. On the right, you have a bunch of very accomplished surgeons observing a procedure on the left. But still, it's a very crowded operating room. You can't see what's going on. And would you want this guy to be your doctor? I doubt it. I certainly wouldn't. So medical training is broken. Let's fix it. First, breed the surgeon. So surgical headgear and surgical equipment in general tends to be extrapolated from 18th or 19th century technology. Here on the left, you have jewelry making loops and essentially a mining helmet on a surgeon trying to see what's going on in front of them in the anatomy. On the right, you have an orthopedic surgeon performing a knee replacement surgery, wearing essentially a spacesuit with all the stuff the guy on the left has in his helmet to protect him from the bone dust that is floating around the operating room during this procedure. Microscopes, again, 19th century, 18th century technology, ground glass brought into the 21st century. The main physician is sitting for hours on end in an uncomfortable position, looking into the microscope at essentially a fixed focal distance, very uncomfortable physically. The assisting surgeon, as you can see, has a fixed position, cannot move throughout the field, and has no autonomy while looking at a 3D scene in 2D. So this needs to be improved. Modern navigation, which is what you're seeing here, is the process of registering 2D images like an X-ray, a slice of an MRI or a CT to the 3D anatomy in front of the surgeon. This is state of the art. So you see the doctors looking across the room at effectively an X-ray from the 1960s, digitized. He is trying to think and act in 3D while doing translation between 3D and 2D and back and forth. Humans are just not good at this, and we shouldn't ask them to do it. Against this context, he is trying to perform a spinal fusion surgery and place that yellow screw very precisely at a sub-millimeter level within the human body without making any errors. Really, this is ridiculous and it needs to change, and that's what Proprio is doing. In order to even use that navigation system, he has to expose himself to tons of radiation. So here you see doctors putting on 20 and 30-pound lead suits to protect themselves from that radiation. It doesn't work well enough, and orthopedic surgeons have about a 7 times increased risk of cancer relative to the general population. It's even worse for women surgeons who experience a lot of reproductive issues. This is not what we meant by the Hippocratic Oath when we said first do no harm. Physicians shouldn't have to expose themselves to this kind of harm just to help patients. We need to do better on both of their behalf. This is what's called surgeon support system. So this piece of equipment is entirely focused on holding that 20 to 30 pound piece of lead up. And you can see the doctors on the right are really excited about it because they don't have to bear that burden. Frankly, we've reached the edge and the limit of what the human body can do in this context, and we need to do better for the surgeons here. We talked about the aging population. There's an aging doctors issue as well. This is Dr. Rothman, founded the Rothman Institute, one of the most famous orthopedic surgeons in history. He practiced until he was 80 years old, retired, and within 6 months he had passed away, taking all that institutional knowledge of 50,000 knee and hip replacement surgeries with him. He's not alone. 52% of orthopedic surgeons are over 55 years old. So we need to address that knowledge gap that is looming. Surgery is very complex, so the cognitive load is really high. This is a map of a complex cardiac procedure. You see the RN or the nurse. Cognitive load ramps towards the end of the procedure when the nurse is asked to do more. Here's a technician who's assisting the surgeon. Is a high ramp towards the middle of the procedure when the complex portions of the surgery are occurring. Now here's the surgeon. As you can see, over a many-hour surgical process, the surgeon's cognitive load is ramped well beyond the nurse and the technician and is sustained at that high level for multiple hours. Our hypothesis here is that if we can lower that cognitive load, flatten the curve is a common phrase these days, we can do a number of things. One is make the procedure more efficient, more effective, and reduce the number of errors. The surgeon is more focused and can focus on what matters most, therefore be more efficient and effective. The second one is very exciting as well. If you free up your cognitive load, and we all know this from multitasking, you get more creative. You have more mind share and mind space to come up with new ideas. So the hypothesis is that if we free up mind share for surgeons and technical teams here in the operating room, they will be able to come up with new procedures and new techniques to solve problems in medicine that today are unsolvable. That's very exciting. In the context of the operating room, it's a very expensive place to be. You have a lot of experts, as you can see, a lot of medical degrees, and a lot of billable hours and billable minutes. Baseline estimates are $100 an hour, $100 a minute in the operating room. That gets expensive very, very quickly. And it's an operating facility of low efficiency. There's a lot of opportunity to improve that quite a bit. All of this leads to high surgeon fatigue. 77% of surgeons report burnout and low morale. COVID-19 has only accelerated and increased this. We need to do a better job of making the job itself easier for surgeons going forward. Doctors are struggling, let's help them. How do you really build a business that truly helps people? We call it truly human design. So we spend a lot of time with physicians, both in person and with their data and with their feedback, diving into their pain points. You see here in these photos, part of our team of highly experienced PhDs, world experts in robotics, computer vision, light field imaging, medical imaging, and AR, VR, as well as software and hardware engineers, really living the experience with the surgeons. They've never been listened to in this way and seen it translate to a product that actually makes their lives better. Additionally, you need to liberate the operating room. When the average operating room in the US went from 400 to 600 square feet, all that happened is the amount of equipment doubled. We talk about surgery today being all about workarounds. My co-founder, Dr. Browd, when he goes into the OR, has to dodge many people and pieces of equipment just to get back to deliver on that Hippocratic oath from physician to patient as it was intended to be. So we need to get back to that. Technology can help us get there with good design. So this is what Proprio is doing. This is the light field imaging system that we've built. It enables surgeons to perform better by digitizing the entire surgery for the first time ever, simplifying complex information through calm design, and replacing over $2 million of equipment day one. This is the game changer. So how do we do it? What is a light field? A light field is a mathematical function for processing all of the light going in every direction through a defined space. Well, what does that mean? So think about the light in the room between me and the camera, or between me and you, the light in an operating room going in every direction, or in our solar system. Each of those is a system that can be defined with parameters. If you had an infinite number of cameras, you could capture every ray of light theoretically in that space, and then render all of that and be able to move around that scene dynamically. That's been done in a post-processing sense, but never in a live real-time sense. I believe we have a video to demonstrate that. So here you have a number of cameras pointed at the same scene, capturing a live light field view of what's happening in front of the sensors. Now you're able to render a volume that the user can move around dynamically. So remember that microscope image and the crowded operating room. Now we have a seamless view where the viewer's perspective, what you can see, is decoupled from your physical location. That means surgeons from anywhere in the world can come in and actually participate in the same surgery real time. This solves a problem in medical training where a trainee can't actually tell what Dr. Browd was doing in a pediatric neurosurgery case. Now you can see exactly what Dr. Browd was looking at in real time from anywhere in the world. That's a lot of data. How do you present all this camera data? We capture in excess of 100 gig an hour of data in a calm way, in a way that you can actually interact with and reduce that, that cognitive load. This is quite a challenge. So on the left, we have the Concorde supersonic airliner, which it was a very complex environment in which to operate. A surgeon is much like a pilot, and they have to monitor all these bells and whistles and possibilities, and they have protocols and sub-protocols, which contributes to that very high cognitive load. On the right, you have the Gulfstream G600, a very simplified design and experience for the user. You have screens that are showing the outside of the cockpit. You have a heads-up display on the left there for the pilot, and you even have mind share, if you will, in the cognitive load to have an iPad, as you can see on the right there in the co-pilot's chair. So this is how we frame up what's going on in the operating room and what the surgeon needs to process. If you can simplify, calm design can actually bring up just the right information at the right time, the right way. So that look like. This is the Proprio system in action. So surgeon can beckon the array into the scene automatically on a robotic arm. You have live fields that are captured from all the cameras. That's all volumetrically fused. You can use an AR and VR headset to interact with the preoperative plan. Here you see real light field data and real CT data fused live, with the yellow line being the preoperative plan that either we have suggested or the surgeon has selected. Think of this as the ghost driver for the real world. It's the optimal performance path. It's never been possible before to pull this in. Now you can magnify inside the body and effectively simulate any decisions you are about to make and minimize the impact on the patient. In this procedure, if you go through that wall right there in the pedicle of the vertebrae, it's permanent nerve damage for the patient. So being able to, at the micron level, ensure you're performing as close to flawlessly as perfectly as possible is a total game changer in surgery. And we can do this for all of surgery. And we call this the new way of seeing. A complex spinal fusion surgery costs between $90,000 and $150,000 per surgery. We aim to reduce that by half and then do that for all of surgery. Together, we will use technology and comm design to build a better experience. And that's our vision of the future. I'm happy to take some questions. Thank you.
Thanks, Gabe. That was a fascinating presentation. I loved the history tour.
Yeah, it's pretty amazing where surgery has come from, right?
Yeah. So with all of that, technology that you're either replacing or that surgeons have had to put up with over the years, are you encountering any resistance as you bring this to market, and resistance from surgeons about adding new technology to the OR?
Yeah, certainly there's a high bar with respect to regulatory compliance, as there should be, right? FDA and all of that. And there's the right amount of resistance there, and we're fully supportive of that path. From the surgeon's perspective, irrespective of how long they've been practicing, how old they are, or what technologies they're using now, it's a widely known truth that the operating room is living in the past, decades in the past, with respect to technology and advancement. So in general, we may encounter some skepticism about some of the things that we claim we can do, but when we get a surgeon here in one of our operating rooms and put them a headset on them, they're very grateful to have, advanced technologies and technologists developing specifically for them, and really bringing the principles of user-centric design into the operating room, and also incorporating kind of continuous improvement approaches to how you iterate, almost in a software sense, but both encompassing both hardware and software. So they're super excited. They haven't been listened to and had their insights translated in this way into products as quickly as we're doing it. So they're always very fired up.
That's great. I was going to ask you about the challenges of acceptance, FDA, medical boards, various hospitals. What resistance have you encountered?
Yeah, certainly. Like the FDA has been actually really good about telegraphing kind of where they want to go with respect to these what we call core technologies. So computer vision, machine learning, robotics, AR, VR, and even prior to COVID and that sort of potential disruption, FDA was kind of telegraphing where they wanted each of these technologies to go and what the bars were for regulatory compliance in terms of measuring exactly how accurate a camera system is to track a tool or an object or the anatomy in the scene. They've actually been very, very clear about what the bars are there, which is great for us because our kind of ethos is in engineering and physics and math, and so the better and greater the precision and the accuracy, it plays into our favor. That's certainly where we come from, being physician and engineer driven. That's the ethos of our company. So no, we haven't encountered any unforeseen kind of guidance or decisions from FDA. They've been a good partner.
Great. You've got quite a diverse background. So I wanted to see if you could expand a little bit on your journey from all of the things you've been involved with into the OR, let's say.
Yeah. There's a funny picture of me as like an 8-year-old stomping on aluminum cans when I lived in Southern California, trying to turn those in for I think a penny each. And one of the talks I've given at commencements and stuff is that's not a very scalable business, very labor driven. And so ever since that time, I've been kind of pursuing more scalable applications of technology and effort, and really been trying to target through my work at the Gates Foundation and other places, how to have a scalable impact on humanity more broadly. And this has brought us here. My background, I was engineering in Japan, law in DC, mergers and acquisitions, Wall Street, all only moderately rewarding, really from a human perspective. And then moved back to Seattle to work with the Gates Foundation to get a little more satisfaction when it comes to pursuing a life and a career where you can do well and do good. So we're fortunate here, and I think everyone at Proprio, we're about 25 full-time employees now, is very focused on that mission of, we basically think about it this way. Every human in the world today will need access to complex medical care at some point, right? We're all going to need a surgery or some treatment like that at some point. About 5 billion people on the planet today do not have access to adequate medical care, including surgery. So if you think about it that way, what we're doing could potentially impact every human alive today and everyone born in the future. That's pretty compelling. And that's what really compelled us to start the company with Dr. Brown, my co-founder, was if it wasn't that ambitious and that potentially helpful to everyone, we didn't really want to do it. But it's proven to be a very motivating mission for sure. Challenging, but motivating.
Awesome. There's tons of positive comments in the chat room. Just a couple of questions. How could this system reduce cognitive load for the surgical assistance team?
Mm-hmm. Yeah, so we got that completely wrong in the beginning. We thought, oh, sweet, we're going to put a VR headset on somebody. We've got infinite virtual 360, everything. And we can just pop up screens and everything you want. You can have a little EKG going over here. The anesthesiologist is going to have this and that. We got it totally wrong. So that's how we got to calm design, was actually, it's much more important what's going on in the background and what little information you present, but at the right time in the right way. And so we kind of came to that conclusion about 2.5 years ago, and we've been just refining everything. So even in the videos you saw in the presentation, there's a lot more complex stuff going on in the background. But for every member of the operating team, whether it's anesthesiologist, tech, nurse, primary operating physician, a resident, each of them should be able to access the most important information to them at the right moment. So in that sense, it's an intelligent learning system where the scrub tech could know exactly what screw or piece of hardware or implantable is next on the operating plan, and that pops up. The system can verify, a future version of the system will verify that you're putting in that particular screw in the right part of the body. Some of those things we can already do today. But essentially it's taking every individual human in that equation, trying to optimize their ability to perform at the highest level, and reducing the portion of their cognitive load that should go to other jobs, right? So it's not so much replacing a human as it is focusing the person on the most important aspects of their jobs, including the lead surgeon, who, as you saw in the table, it spikes pretty high relative to everyone. That's in a heart surgery, but brain surgery is equally complex. So our goal is to go through one by one through that user experience and just focus the human even more.
There actually is a question in the chat room, specifically around the applications of Proprio in heart surgery. If you could maybe keep that answer tight because we're a little over time, but I want to make sure you got to address.
Yeah, I'd say we see this as applicable to every type of surgery. It's basically anywhere you can get a sensor or camera array, in the body, above the body, around the body. Our aim is to capture all those data and represent it in a more useful way. So you would start with complex open spine heart surgery, right? So cardiothoracic surgeons have been big supporters of what we're doing. And then you're going smaller and smaller down to the endoscopic level, right? And then you're going in with minimal incisions over time. So that's our goal, is to get to the smallest impact, the lowest impact on the patient's body, and the fastest recovery time. So the first thing to do is make sure the first surgery is successful. The second is to start to minimize everything and miniaturize it and bring it inside the body. And that's the path we're on. So for heart surgery, eventually tracking both hard and soft tissues movements in real time using light field. But that's the path that we're on.
Excellent. Well, unfortunately we're out of time. Thank you so much for your talk. But we do need to move on to the next topic.
Yep.
Thank you again.
Thanks a lot. Take care. Thanks for the questions.